न्यूरो ज्ञान यूट्यूब चैनल पर आपका स्वागत है। लेटेस्ट वीडियोस के लिए अभी सब्सक्राइब करें।
And in bilingual patients like Mr. Raykwar, we can ask him the transcription between Hindi, that is Devanagari to Roman, and Roman to Nagari. Speech and language are not the only higher mental functions affected in aphasic patients. There are many more which should be tested at the end of a speech assessment. They include praxis. Praxis is the ability to carry out highly coordinated motor tasks on command. For example, we ask a patient to lit a cigarette or to lock or unlock a lock with a key. Another higher function is gnosis or recognition. Recognition of objects, matching the object with other similar or dissimilar objects, and also the faces. Other higher functions are memory, which includes immediate recall, recent memory, memorization, and remote memory. We have also paid attention to calculation, to right and left orientation, and music, the reading of music language and the composing of music in its language, and appreciation of music in its all subtleties. These higher functions should be tested so as to assess the full impact of the lesion in the brain on various higher functions of the patient concerned. All aphasics do not have same degree of clinical disability. It varies widely. Some are mildly affected, some are more severely affected. At one end of a spectrum, in the grade 0, there is effectively no communication, neither expressive nor receptive. Then from grade 1, 2, 3, gradually the onus of communication or the responsibility of communication shifts from the examiner to the patient also. He also starts sharing, and in grade 5, which is the mild variety of aphasia, it is almost nearly normal. Aphasia is not one single homogeneous entity. There are many types, many syndromes, which are divided according to the constellation of clinical deficits. Such a classification has many uses. It is useful for descriptive purposes. It helps in clinico-anatomical correlation with the lesion in the various parts of the brain. It helps in planning the speech therapy, and it also helps in understanding the language organization in human brain. Of the many syndromes, most severe is global aphasia. Our audience might remember the example of Champabai, who was not able to speak or understand anything. All aspects of speech function are severely affected. Broca's aphasia is characterized by motor or expressive deficit with non-fluent speech but relatively preserved auditory comprehension. And the example was Mr. Rameshwar Porwal. These patients also have affected naming, repetition, reading, and writing to the same degree of severity as the fluency. Only the auditory comprehension is relatively preserved, and the site of lesion in brain involves the inferior frontal part. The next example is Wernicke's aphasia, in which there is a fluent speech with lack of content words, jargon, meaningless, paraphasic words. And the example was Mr. Surajmal. They speak very fluently with normal melody and normal articulation, but their auditory comprehension is extremely poor, and also the reading comprehension. Their naming and repetition are also as severely affected as their comprehension. Another example, but before that, the site of lesion in Wernicke's aphasia is superior temporal gyrus. Another example is conduction aphasia, in which the task of repetition is markedly affected. They are not able to repeat whatever we ask them to after us. Yet there are other functions like fluency, auditory comprehension, naming, reading, and writing are relatively better preserved. And the part involved in the brain is known as arcuate fasciculus, which is a bundle of white matter fibers joining the Wernicke's area posteriorly with the Broca's area anteriorly. In contrast, transcortical aphasia is a syndrome in which the function of repetition is surprisingly better preserved, while the fluency or the auditory comprehension may be affected much more severely, and the lesion in such cases does not involve the main sylvian regions of the Broca and Wernicke's area, but the surrounding perisylvian parts in the anterior and posterior parts of the brain. There is another syndrome known as anomic aphasia, in which the function of naming is selectively affected while other aspects like fluency, auditory comprehension, repetition are better preserved, and the part affected in the brain is angular gyrus. In actual clinical practice, however, we encounter many patients in whom the speech deficits cannot be put into the specific aphasic syndromes. Their clinical picture overlaps into one another. Such exceptions are not uncommon. And also regarding clinico-anatomical correlation, that means the correlation between the type of speech deficit and the type of brain lesion, they also vary from patient to patient. While most of the generalizations are true for a big percentage of patients, it is these exceptions or deviations which tell us more about the organization of higher functions in the human brain. People knowing two or more than two languages may exhibit different types of aphasia and different degrees of severity of aphasia if they suffer a brain damage. One language may be more severely affected and may recover slowly, particularly if that language had been learnt later on during the life, while the mother tongue or the first language may not suffer so much in aphasia and may recover earlier. However, the subject is not so simple. There are many complex exceptions involved and which shed enough light on the organization of language in brain with reference to typology of language, different types of language, with reference to pedagogy of language, the way the languages have been taught, and with reference to the interaction or interference between the two languages. All these things complicate the issue of bilingual aphasia. Dr. Ajay Kothari is MD Medicine, a physician who suffered aphasia. He had been using English in his medical teaching and reading and education and also in daily use, and yet he is able to perform better in Hindi, which is his mother tongue, as compared to English. Most of the people, about 90%, use their right hand for daily activities like eating, writing and other actions. But about 10% may not use the right hand so preferentially. However, if you restrict yourself to inquiring only about eating and writing, many more people would say about the right hand, because cultural and social factors force the people to use the right hand even if they are left-hander. It is very important to ascertain the handedness of the patient in aphasia by asking them a host of questions about the preferred use of hand they do in different works. For example, we ask these patients with what hand do they write, do they eat, do they flip a coin, do they use a scissor or a hammer or play a card or throw a ball, or we can really ask them to demonstrate the actions. And by enumerating the results in different tasks, we ultimately determine the handedness quotient, the percentage, in how many activities he is using his left hand versus right hand. The handedness quotient is important from the language dominance point of view. In 98% of the right-handers, it is the left cerebral hemisphere which is dominant for the language function, and a lesion in this hemisphere, this part of the brain, will lead to aphasia and not in the right hemisphere. In the 10% who are left-handers, the right hemisphere is dominant for language function in about 50% cases, and in such cases, a lesion in the right hemisphere will lead to aphasia. The tragedy of aphasia can be overcome to a great extent with the passage of time, with patience, with perseverance, with great effort, under the expert guidance of a speech therapist. And rehabilitation aims can be achieved to a great degree. Dr. Ajay Kothari, he is an MD medicine physician who suffered cerebrovascular accident and a severe aphasia a few years back. And now he has rehabilitated himself to a great extent that he is able to consult his patients in the clinic, able to prescribe, though he needs some help. How this much degree of rehabilitation could be achieved, that depends on the efforts. And I also have Dr. Swami Sridhar, an experienced speech therapist and pathologist, who has been dealing with such patients. Dr. Swami Sridhar, I would like to know your views about the utility of speech therapy in rehabilitation. Is it helpful in every patient, and how do you select your patients, and what are the circumstances under which you get better results?
Speech therapy is highly helpful, but it depends. Because of the complexities involved with cerebral lesions, sometimes you may get amazingly very good results, and sometimes so demoralizing results both to the patient as well as to the speech therapist. But it entirely depends upon number of factors: the motivation of the patient, the intellectual ability of the patient, the family circumstances, family environment, how much support he is getting from the family members, all these and the degree of damage or the severity of damage, all these things contribute to the overall improvement.
Right. But in those patients who are very severely aphasic, for them also we can have some communication boards, like I want to show you here. These are the boards with pictures, and patients can put their finger onto the object. They may not able to utter the word, but if we can train them, if we can train the family, and there are some other communication boards like this, in which some of the common sentences used in day-to-day are written, and if we can teach the patient that here is the sentence for this need, here is the sentence for this need, and if we can merely point out the finger, those who are with him in the family and those who know how to talk to him, they might be helped to some extent, even the severe ones.
Communication does not necessarily mean verbal. You see, if the patient is able to communicate by verbal means or non-verbal means, that is okay. So we can use objects, we can use verbal symbols, gestures.
Yeah.
All these things are going to help.
How soon the speech therapy should be started? What should be the frequency, and when should we terminate it?
Speech therapy must be started at the earliest, as soon as the patient comes out of the critical situation.
Say about 2 weeks.
Yeah, maybe about 15 days or so. We must initiate therapy. And as far as frequency is concerned, frequency must be as frequent as possible, maybe even 2 to 3 sessions per day. But unfortunately in our country, there are not many speech therapists around. So it may not, and for those places where such facility does not exist at all, family people can learn from the speech therapist,
and then they can continue the work at home.
They can continue, and maybe they will be able to do it in better and more natural circumstances.
How long you go on doing it?
Well, till we reach a plateau. If we periodically we assess the progress the patient has made.
What are the methods and stimuli and the objects you use?
As far as methods are concerned, there are no definite methods. A methodology could be different from patient to patient. That entirely depends upon the speech therapist as he assesses his patient.
So it is all individualized.
Yeah, it is highly individualized, though there are certain standardized materials, standardized stimuli, standardized procedures. But then, using those standard techniques, the speech therapist modifies the method to suit the individual needs of the patient.
What is the role of family, and particularly some of the do's and don'ts, some precautions for the family members and for the person who once know that this is a patient suffering from a speech problem? We can guide them how to talk and how to converse with this fellow.
Family plays a very, very important role, especially in those areas where expert help is not always available. And also it is in the family that the patient spends most of his time. So if the family people are cooperative, then we can achieve much more than in a therapeutic
Now,
setting.
for example, should the family member always provide the word if he is not able to utter a particular word?
You should give them cues. That is only initially. So as the patient progresses, then these facilitating techniques should be reduced to a minimum.
डॉक्टर अजय कोठारी, अब आप क्लिनिक में क्या क्या कर लेते हैं?
ECG कर लेते हैं, शुगर की जांचें कर लेते हैं, बॉटल लगाना तो वो भी हो जाता है हमारे यहाँ।
डायग्नोसिस बन जाती है
हाँ जी, हो जाता है।
और प्रिस्क्रिप्शन
दवाई लिख देते हैं। अब तो ऐसा लगता है कि ज़्यादा क्लिनिक में अच्छा लगता है मेरे को।
क्लिनिक में अच्छा लगता है। जब ये आरंभ में हुआ था उस समय आपको उम्मीद थी कि आप इतना कर पाओगे?
पहले तो लग रहा था कि जल्दी हो जाएगा, लेकिन फिर बाद में लगा कि बहुत टाइम हो रहा है।
हाँ।
फिर मेरे को लगा कि इससे तो मर जाए तो ज़्यादा अच्छा है।
पर अंततः तो ठीक हुआ।
फिर से ठीक हो गया।
ठीक हो गया ना?
1 साल से जब ये हुआ, क्लिनिक का काम शुरू हो गया, तो फिर मेरे को ठीक लगा।
बहुत अच्छा लगने लगा है। इस सब में आपको अपने परिवार का सपोर्ट मिला, आपको उसका कितना महत्व समझ में आता है? फैमिली सपोर्ट की क्या वैल्यू है?
हाँ, काफ़ी किया उन्होंने। उसके बिना तो क्या करता, मैं
उसके
अकेला
बिना
तो
तो
कर ही
आप
नहीं
कुछ
सकता।
अकेले नहीं कर पाते।
पहले तो खाना खाना है कि नहीं खाना, क्या खाना है ये नहीं बोल सकते ना।
हाँ।
अब तो मालूम पड़ गया, लेकिन पहले तो बिल्कुल नहीं मालूम था
बोल
ये।
पाते थे। थैंक यू डॉक्टर अजय। राइट। Aphasia or paralysis of speech is a great tragedy for the patient and his family. It is nature's cruel experiment on human brain, which, however, gives us an opportunity to learn about neurophysiology of language functions. A large number of clinicians have labored hard over the last 100 years or more. They have studied in detail the speech deficits of patients suffering with aphasia. And when these patients died, they dissected their brain to determine which part of the brains were damaged. This was like putting a jigsaw puzzle together. Nowadays, we don't have to wait for the autopsy or postmortem. In a living brain, we are able to study with the help of MRI or CT scan or PET scan. This whole branch of aphasiology has told us a lot about the language function in the brain, a part of which was covered in this series on paralysis of speech. A new field of interdisciplinary nature known as neurolinguistics has emerged in the last few decades. Neurolinguistics deals with interaction between neurology of aphasia and linguistics. Many theories of linguistics and hypotheses have been put to experimental test because of aphasic patients. And a lot of interaction is now also occurring with the fields of information processing and artificial intelligence. Ultimately, the unifying concept of the word and the meaning, Vani and Arth, is leading us to the God, the most supreme being, as said by Kalidas in Raghuvansh or Kumar Sambhav, Vagarthau Sampraktau Uma Maheshwarau. Vani and Arth, the word and the meaning, are as inseparable as Uma and Maheshwar are Shiv and Parvati. It is in the quest of that knowledge in the human being, it is the language which signifies or identifies a human being, that this branch of aphasiology is striving for.